the surgical management of hypertrophic obstructive cardiomyopathy. So we'll discuss about surgical rule and the 2014 European guidelines. So the first of all, the hypertrophic cardiomyopathy is a genetic myocardial disorder characterized by the left and right ventricular hypertrophy, and that usually not always symmetric and associated with the microscopic evidence of myocardial fiber disarray and fibrosis. Prevalence around 0.2%. So the previous nomenclature, it was named functional aortic stenosis or idiopathic hypertrophic subaortic stenosis, hypertrophic obstructive cardiomyopathy. The first description of the HOCM was 1957 by Brock. He was described diffuse muscular subaortic stenosis, and he incorrectly concluded that etiology of the muscular hypertrophy was likely due to systemic hypertension. So the patient does not underwent the surgery at that time. A year after, 1958, Attir is a London pathologist. He described the thickening of the ventricular septum compared with the free wall and the myocardial fiber disorganization or disorganize the myocytes, and for the one patient who died suddenly. The first surgical attempt was done by Goodwin and his colleague Cleland in 1958, and only small amount of hypertrophied muscle was excised and was high mortality. After that, in 1959 and 1960, Kirkland and Hurley at the Mayo Clinic operated in 2 patients using combined transaortic and transventricular approach. And the vertical aortotomy was made to allow the left ventricle, left index finger to pass through the aortic valve, and ventriculotomy was done by the finger, the hypertrophic lesion identified, and then the ventriculotomy was done in that side. Again, is high mortality. And after that, the Morrow 1960 the National Heart Institute in the Maryland aimed to relieve the obstruction using the subaortic ventriculomyotomy without resection any muscles. So from the apex to the aortic annulus, incision over the muscle protruding into the LVOT, either with the conventional knife or malleable finger knife like this. With the finger, with the index of with the finger, the muscle fiber split to create a little split to allow the ventricle to accommodate the blood. And after that, in 1964, 1975, the Morrow again refined the surgical treatment, combined ventriculomyotomy with the partial resection of hypertrophied muscle. And instead of using malleable finger knife, the 2 parallel incision with the blade, and the knife was inserted directly into the septum beneath the right coronary cusp. So now the etiology of the HOCM. The HOCM is transmitted as autosomal dominant, and it's caused by mutations and genetic, and there is other non-genetic disorder. Mutation beta myosin, heavy chain, and cardiac troponin, and chromosome 1, and alpha tropomyosin. And the mutation around around 40 to 60 due to sarcomere protein mutation, and around the 5 to 10 the other non-genetic disorder like the mitochondrial disease or neuromuscular disease. we'll come to the morphology. The HOCM involves the interventricular septum and left ventricle and is variable in its location and severity. Ventricular septum is in classic HOCM, hypertrophy is maximum in the distal cephalid portion of the ventricular septum. The point of maximum thickening is just apical or caudal to the free edge of anterior mitral valve leaflet in its open position, and taper off gradually toward the left ventricular aortic junction and towards the apex. Mid-ventricular hypertrophy, ventricular septal hypertrophy at the site below the anterior mitral valve leaflet, adjacent to the papillary muscle. And usually in this, there is no SAM or mitral regurgitation. In dynamic morphology of the septum and mitral valve, when septal hypertrophy is classic, obstruction is between hypertrophied ventricular septum and anterior mitral leaflet. And during the systole, the posterior mitral leaflet close against the body or belly of the anterior leaflet of mitral valve, and this will lead to the angulate of the anterior leaflet towards the aortic annulus and causing the SAM. I will come to the SAM now. So the SAM in HOCM is multifactorial, and there is two mechanisms. It's Venturi effect. Come to the picture. The Venturi effect, as we know, in the HOCM there is LVOT obstruction, and that's why the velocity of the blood there is higher velocity and that in the LVOT, and that's why the higher velocity will create a negative pressure here and will suck off the anterior mitral valve leaflet towards the aortic annulus. And after that, the ejection of blood, the ejected blood from the left ventricle, it will force the anterior leaflet, and that's why it will create or increase the mitral regurgitation. And there is other some theoretical articles. They say the displacement of the anterior papillary papillary muscles will cause the SAM. The left atrium is often dilated and thick-walled as a result of decreased compliance of the LV and presence of mitral regurgitation. Mitral valve, the intrinsic mitral regurgitation, about 20% of the patient with HOCM. Right ventricle hypertrophied of the ventricular septum lead to the project into the RVOT and increase the gradient in the RVOT. And the hypertrophy may cause the right ventricular hypertrophy secondary to the pulmonary hypertension from the long-standing of the heart failure of the left side. So the coronary arteries, usually coronary arteries larger than normal in HOCM patient, and there is a muscular bridging of the LAD during its course. It's more common in HOCM. LAD more become totally occluded during the systole, and the septal perforating arteries may be obliterated or narrowed during the systole. And that's why there is the myocardial ischemia in the HOCM is common manifestation. Subaortic or mid-ventricular obstruction may be latent or labile or persistent. The clinical feature and diagnosis criteria. The palpitation, the AF, usually initially by paroxysmal, but it's permanent in about 10% of the patient, and premature ventricular contraction or FTAC, supraventricular tachycardia. In the later stage, the heart failure may be with the paroxysmal with the manifestation of the heart failure in later stage. The signs, the three cardinal signs in the HOCM: the latent onset, the systolic ejection murmur between the left sternal edge and apex, and vivid arterial pulse, palpable left atrial contraction. Murmur, the mid-systolic murmur, proportional to intensity to the degree of obstruction. And between the left central edge, the location of the murmur between the left central edge and apex of the heart, and murmur usually increase intensity after falsetto maneuver because the falsetto maneuver decrease prelude, and that's why the increasing the gradient increase obstruction. In diagnosis, usually by the echo, the ECG showed the LV hypertrophy, occasionally complete left bundle branch block, and more left anterior hemiblock. Echo usually depends on the peak gradient, not the mean gradient. LVOT is defined as the peak gradient more than 30 at rest or during physiological provocation, such as falsetto maneuver or standing or exercise. Gradient more than 50 is usually considered to be the threshold for the important hypertrophy, and the single most relevant parameter is the maximum LV wall thickness at any level. If segment is not visualized adequately, you can use the contrast echo. And here the stepwise approach to define the obstructive physiology. If there is a gradient more than 50, so this is the more than 50, this is the obstructive. If no falsetto gradient, and if more than 50, so it's obstructive. No will give some dilator, vasodilator, so to decrease the prelude and increasing the gradient, and we'll see if the gradient is more than 50, it will cause physiology. And this of the patient symptomatic, and we'll do the stress gradient of more than 50, or the cath gradient more than 50 is obstructive physiology. And this is the echo showed the interventricular septum during the diastole, and this is during systole, and you can see the obstruction of the LVOT here. So associated abnormality of mitral valve during the left ventricle, as we mentioned before, the SAM is common in the obstructive HOCM, and you can see the anterior leaflet of mitral valve in into the LVOT. And this the direction of the mitral regurgitation, and usually mitral regurgitation inferior laterally and not anterior centrally or the anteriorly. SAM will lead to the mitral regurgitation and mid to late systolic and inferior-lateral oriented regurgitation. The central or anterior directed jet of mitral LMR should raise suspicion of intrinsic mitral valve abnormality. So here, from the European guidelines, protocol for assessment and treatment of the LVOT obstruction by 2D echo of the maximum provoked peak more than 50, so we'll go to the symptomatic patient pathway. If the provoked less than 50, again, if it is symptomatic, we can repeat the echo 1 year, and we'll come to the follow-up. And the symptomatic, in case of symptomatic patient, we'll do the exercise stress echo, and if the gradient more than 50, we'll go to the same tract. And maximum less than 50, we'll go to the medical management. So MRI superior to the standard 2 echo in case of the LV apical or anterior lateral hypertrophy or aneurysm or any source of thrombi. So now the guidelines of the echo and HOCM according to the 2014. And there is 2011 American College of Cardiology. The class 1 is the echo, initial evaluation by echo or during falsetto maneuver or during the exercise if no gradient is provoked. Measurement of maximum diastolic wall thickness by 2D or short axis view on all LV segments from base to apex. An evaluation of the because maybe the obstruction will be in mid ventricular or apical, so we have to do all the segments. Evaluation of the LV diastolic function, class 1, in case of symptomatic patient with the resting or provoked peak gradient less than 50, so we'll do the exercise the 2D or Doppler in setting or in standing position, and this is class 1. Class 2B, in case of asymptomatic patient with the resting or profute gradient less than 50, we'll do 2D, again, the same, 2D or the Doppler echo. Class 2A, in case of the suboptimal imaging, or in case of the LV hypertrophy or aneurysmal, the apical aneurysmal, will do the contrast echo. And this is the class 2A. And T for sure is class 1 and recommended in patient undergoing septal myectomy to confirm mechanism of LVOT and to guide the surgical strategy and to assess the post-surgical complication and to detect any residual LV out-of-flow tract obstruction. And if the mechanisms of unclear or assessing the mitral valve apparatus before septal reduction procedure, this is the class 2A. MRI in absence, the class 1 recommended and should be done by experienced physician. And in absence of contraindications, the MRI with the late gadolinium enhancement is recommended in patients with suspected HOCM or who have inadequate echocardiography window to confirm a diagnosis. And the MRI, again with enhancement, gadolinium enhancement, is considered in patients with suspected apical hypertrophy or aneurysm. So CT scan should be considered in patients who have inadequate echo or contraindication to MRI. So this is class 2A. We'll come to the cath of the inconclusive echo, and usually the obstruction, as we know, the obstruction is increased by contractility or any situation that lead to the decreased preload or afterload will lead to increase the gradient between LV and this. You can see this. I think this is the more you can see here. This is the baseline of the patient, and during the falsafa maneuver, you can see the gradient between the yellow line is aortic pressure, and the red line is the left ventricular pressure, and you can see the gradient between the peak of the aortic valve and the LV is increasing with the falsafa maneuver, and because the falsafa decreases the preload. With the falsafa and any ectopic feeds, the gradient is increasing more. See the gradient here between the LV, between the aortic and LV is around 100, and the aortic pulse pressure is decreased. See this is the aortic pulse pressure from 80 to 120, but here from 80 to 100. So this is the characteristics of the cath and in HOCM patient. Natural history, present at any age. Obstruction is present only about 20%. واضح شباب? Can see my slides?
ايوه واضحه. تصدق امس واحد من الكونسلتنت سالني يقول لي in HOCM what is the specific test او شيء زي كذا. قال يعني you can do in the cath lab and you can differentiate between HOCM and other causes for high gradient. طبعا ما عرفتها. فهي هذه اللي انت شرحتها قبل شوي. هو قال بعدين يعني حاول يشرح لي اياها. قال لي انه يعني they induce PVC after the PVC there will be increase in gradient. فانت تقول لانه يزيد البريلود صح؟ او ممكن تشرح لي اياها مره ثانيه؟ صراحه ما فهمت بشكل واضح.
Any situation that needing to decrease preload or increasing contractility, it will increase the gradient between LV and aortic pressure because increasing the obstruction. You know the preload لما يقل عندك البريلود معناته ما في blood يطلع مع ال LVOT صح ولا لا؟
ايوه
تمام.
ايوه
لما يكون في blood يطلع مع ال LVOT blood كميات كبيره معناته انه يفتح لك الobstruction البلد نفسه. لكن لما يكون
ايوه
في decrease في البريلود more obstruction فيكون في gradient between ال LV وبتوين الايورتا.
طيب هذه واضحه بالنسبه لي، بالنسبه للفالسافا مانوفر يعني with increase intrathoractic pressure يقل الفينس ريتيرن يقل البريلود، بس مع البي في سيز هل عندك يعني فكره واضحه كيف بالضبط تصير؟
contractility
by decreasing the contractility.
Contractility increase, it will increase the gradient between LV and aorta. اي شيء increasing the contractility او decrease the load معناته increase the obstruction of the LVOT.
طيب ولها اسم بعد الظاهر، قال اسم لها اسم بدويتش من حاجه زي كذا، ما ادري ما اتذكرها بالضبط. طيب شكرا، واضح جدا.
طيب natural history present at any age. Obstruction is present only about 20%. The clinical course is usually stable over the long period, and the sudden onset of heart failure usually with the precipitated with the AFib. So the risk factor for sudden cardiac death is usually the gradient is at least 30, young patient, or syncope, or family history of malignancy, or sustained ventricular tachy. And there is no any updated about this since 1995. And management, according again to the guidelines, the general measures, class 2A, to avoid the arterial or venous dilator, including the nitrate and phosphodiesterase inhibitor in patients with resting or provocable LVOT. Class 2A, again, restoration of sinus rhythm or appropriate rate control before considering invasive therapy in patients with the new or poorly controlled AFib. Digoxin is contraindicated in patients with the HOCM, with the obstructive HOCM. And medical treatment of the LVOT, class 1, the beta blocker titrated to the maximum tolerated dose is first line therapy to improve the symptoms, and patient with resting or provoked LVOT, if contraindicated or cannot tolerate, you can use the verapamil, non-dihydropyridine calcium channel blocker. Not effective, you can add disperamide as antiarrhythmic medication, but you have to keep in your mind, or you have to take care of this because the QT interval, prolonged QT interval, that you cannot use, or you have to be cautious in the other medication that leading to the increased or prolonged QT interval. Class 2A is diltiazem, and class 2B is thiazides to manage of the pulmonary edema or exertional dyspnea. So septal reduction therapy for example, septal myectomy or the septal ablation, alcohol ablation, the class 1 performed by experienced operator, or to improve the symptoms with the resting or provoked LVOT graded more than 50, and NIHA class 3 and 4 despite maximum medical therapy. And again, the class 1 septal myectomy is class 1 in patient undergoing other endocardiac surgery. The class 2A, recurrent exertional syncope caused by resting or maximum provoked LVOT gradient more than 50 despite optimal medical therapy. MVR, mitral valve replacement or repair in patient with LVOT gradient more than 50 is class 2A in case of symptomatic and severe, moderate to severe MR is not caused by SAM, or class 2B in moderate to severe MR due to our following the septal myectomy, and with the septal maximum septal thickness is 16 or less at the point of the mitral leaflet and septal contact. So surgery versus alcohol ablation, actually there is no randomized clinical trial for this. There is meta-analysis. And septal ablation may be less effective in patients with the extensive septal scarring on MRI, or in patient with the hypertrophy more than 30, but systematic data are lacking. There's no randomized trial in comparing surgery and septal ablation, but the meta-analysis, they showed that both procedure improve functional status with a similar procedure mortality. Septal ablation associated with the higher risk of heart block, permanent pacemaker implantation, and a little bit the residual, is not a little bit, larger residual LVOT gradient. In contrast to myectomy, the most patients develop the right rather than left bundle branch block after septal ablation. And this, the comparing the septal myectomy and septal ablation, and the residual gradient is significantly decreased with the septal myectomy less than 10 and the septal ablation less than 20, and the effectiveness more than 90 and 70 in case of septal ablation. And this is the meta-analysis, septal alcohol ablation versus myectomy, and they found the efficacy of both in the left ventricular outflow tract obstruction is almost comparable, and there is a little significant higher residual LVOT among the septal ablation patient. So we'll talk about the operative technique. Any questions, Shabab? Okay, we'll talk about the operative technique. Myectomy by the aortic approach. As we know, the aortotomy, oblique incision to the non-coronary cusp, and then after that you can by the retractions, ribbon retractor to the right coronary cusp, you can see the septum, and this is the lines of your incision. You can see here the by the knife, by the blade, can make the two incision, one under the right coronary cusp, but make or leave a few millimeter from the right coronary cusp to avoid the prolapse, and the other incision the leftward as possible, and then connect the two incision. And here you can see you can do the RV depression or RV depression by the gauze to expose more septum for you and resect. And this you can remove the additional tissue extend to the commissure between the right and left coronary cusp. And this is the longitudinal view showing the line of resection up to the base of the anterior papillary muscles. And in case of the abnormality of the mitral valve, the papillary muscles, you may face the papillary muscle attached to the belly of the anterior of the anterior leaflet of mitral valve, and you have to resect this. You have to resect the papillary muscle, otherwise you will end up with the residual LVOT gradient. In case of the papillary muscle attached to the free edges of the anterior leaflet mitral valve, and there is no contact with the septum, you can leave this, because if you resect, you may end up with the mitral prolapse and mitral regurgitation. Unbelievable story. You know what this? This is the heart of Dr. Moro. Dr. Moro is diagnosed with the HOCM, and he suddenly died at age 60. And this, if you want to read the story, and this is the article, Father of Septal Myectomy for Obstructive HOCM. The key principle in obtaining adequate relief of the LVOT obstruction is understanding that the depth of septal excision is less important than the length of resected portion. So in case of mitral valve regurgitation in patients with HOCM, and this is the retrospective reviewed around the 2,000 patients from 1993, 2002, up to 2014 at the Mayo Clinic. And they found survival the red line, this mitral valve replacement patient with the HOCM and the underwent mitral valve replacement, and this mitral valve repair. And they found the mitral valve, sulfapyl mitral valve repair is better than the replacement. And they conclude that the repair is preferred because of improved sulfapyl compared with the replacement. In case of mitral valve repair, mitral valve repair is feasible in 50 to 60%
comment kindly.
percent.
Aziz.
Yes.
If you go back, no, the mitral valve against versus replacement. And when I see something like this, in the literature, the first things that will come to my mind, they mention that you need to go for the repair instead of the replacement. But when you do replacement, that means there is extensive resection that done because of the HOCM, and it's more complicated. This is why you go for replacement, not for the repair. So that need to keep it in your mind. You get my point, what I want to deliver?
Yes.
So it is not about repair or replacement. It's about the complex of the procedure and the extent of resection. This is why the repair is better, of course, because it's less. You don't need, as you very nice bring that picture of the papillary muscles, and you said if it is in face of you, you need to cut it. Otherwise, if it's not attached to the septum, imagine if it is really causing obstruction, you need to take the papillary muscle out. In that case, for extensive, you need to do replacement. But because of the complex of that HOCM you are faced with, this is why you go for the replacement, not for the repair. Just I want to emphasize on this point.
Yes.
Thank you.
Yeah, thank you. Okay. And by the way, the mitral regurgitation related to SAM, the mitral valve is relieved through the adequate myectomy. No need to replace or repair. But in case of the mitral regurgitation, severe, or the need to, as mentioned, as Haytham mentioned, need to resect a lot of tissue, valve intervention. Replacement in case of the excessive tissue resection or repair of the repairable. Mitral valve repair is feasible 50 to 60% of this patient, and you have to avoid the annuloplasty ring. However, to prevent SAM, if the annuloplasty is necessary, flexible or rigid bands on the posterior leaflet are preferred. So now we'll come to the results. The time-related survival, the largest surgical series, five-year survival has ranged from 80 to 90, and 10-year survival from 70 to 80. And all colleagues reported the similar data, and the survival 80 to 60. And survival is higher in patients undergoing the isolated myectomy. The modes of the death after discharge from hospital usually from the cardiac heart failure or sudden death, ventricular arrhythmias, and stroke. And risk factor for premature death, usually the older age, female gender, pre-op syncope or increase in EHA class, and coronary artery disease or concomitant procedure, or the development of the complete heart block. And in conduction disturbance, the complete heart block usually from 2.5 to 10, and complete left bundle branch block develops approximately 50% of the patient postoperatively. And heterogenic defects, a recent reported series from the Experience Center, the frequency is less than 1. McIntosh and colleagues believe that the heterogenic VSD is more likely, and the septum is less than 18 millimeter. In case of aortic regurgitation, experience of Brown and colleagues, small aortic annulus, the causes of small aortic annulus, less than 21, or the low mitral septal contact lesion. And due to usually increase probably due to the increased operative difficulty, and that you need increased retraction, and you may injury of the valve cusp, or loss of support of the right coronary cusp, as we mentioned before, as a result of excessive septal muscle beneath of the right coronary cusp. So the solution to avoid resection of a few millimeter ventricular muscle beneath the right coronary cusp may be prevent the prolapse and aortic regurgitation. So the alternatives therapy, the alcohol septal ablation, as we mentioned before, or dual chamber pacing, and decreases subaortic pressure gradient and relief associated symptoms in some patients. The mechanisms is decrease the septal motion and will increase the LVOT tract area and decrease the SAM, or the late activation of the basal septum and decrease the LV contractility. And DDD mood is usually valuable in elderly patient and other patients who are not candidates for the other septal reduction therapy. So the guidelines of the cardiac pacing, the sequential AV pacing with the optimal AV interval to reduce the LV outflow tract gradient, or to facilitate medical management, is class 2A in patient with the resting or provocable LVOT gradient more than 50 and sinus and drug refractory symptoms who have contraindication for the other septal reduction therapy. And class 2B, the patient with the resting or provocable gradient more than 50 and sinus rhythm or drug refractory symptoms, who there is indication for ICD implantation. So now we'll move to sudden cardiac death. I think the sudden is the one of the complication from the complication of the HOCM. Usually, the estimating the sudden cardiac death risk, no randomized trial or any validated score for sudden cardiac death or for risk of sudden cardiac death. So all the recommendation based on observational and retrospective cohort study. And you have to remember the 3 or 4 things is the variable or the parameters of increasing the risk of the sudden cardiac death: severity of the LVH, family history, and unexplained syncope, and history of cardiac arrest. So recently, the multi-center retrospective longitudinal cohort study around 3,000 patients, known as the HOCM risk sudden cardiac death, developed and validated a new score. And the probability of sudden cardiac death at 5 years is 1 minus 0.998 multiplied by prognostic index. Prognostic index is a long equation, but we have to remember the maximum alveolar thickness, family history, and sudden cardiac, and the family history of sudden cardiac death and unexplained syncope. So the guidelines of ICD implantation to prevent sudden cardiac death, there is 2 kinds of prevention: primary prevention or secondary prevention. Secondary prevention, who patient who had the history of cardiac arrest or any high risks like the VTAC or VF. And so this the life expectancy more than 1 year, so ICD is recommended to implant. The primary prevention, the patient with the risk variable like age or family history or unexplained syncope or the LVOT gradient. So we need to define or to know the score of this patient. The score is, as we mentioned before, the equation score either low risk or intermediate risk or high risk. The low risk is less than 4% or intermediate between 4 and 6 or high more than 6. So if the low risk is contraindicated to or no recommendation to ICD implantation. Intermediate risk is class 2B to implant him, and high risk is class 2A to implant him as a prevention. So now we'll talk about the follow-up. The follow-up of the patient with HOCM, the class 1
what the component of the score kindly?
This هذا واضح أيضا؟
No, the
slide
component.
واضح؟
No, it's very clear. The component of the score. Yani when I do the score, what I have to calculate.
I don't know exactly the other equations. I don't know exactly how to calculate that less than 4 or more than 6. I don't know exactly. I didn't find it in the literature. I didn't find it in the guidelines and the other articles. You mentioned you mean why they're more than 4 or less than 6
No.
from the numbers? You mean the number 4, 6?
No. The score itself, like in the STS score, in the Euro score, I need the score or the link for the score, so I can see the variables.
الفاريبلز موجودة
exactly.
هذه الايكو بارامترز كلها موجودة واشياء من الهيستوري wall thickness left atrial dimension هذه اللي تقصدها؟
Yes, this is the one.
I think
موجودة بس لأن في أرقام واجد فملخبطة.
Okay, خلاص.
موجودة في الكالكوليتر something like this. هي موجودة I think في الكالكوليتر حق الميديسين.
I will check.
طيب. Okay, the follow-up of the HOCM class 1 of the patient stable ECG and echo every 2 years, every 1 or 2 years. If the patient complains from new palpitation, 48-hour ambulatory ECG is every 1 to 2 years of the patient stable. In case of the every 6 to 12 months in patient with sinus rhythm with the left atrial dimension equal or more than 4.5. Class 2A is in case of symptomatic limited exercise testing every 2 to 3 years in clinical stable patient or every year in patient with the progressive symptoms. Class 2B, MRI every 50 year in stable patient or every 2 to 3 year in patient with the progressive symptoms. And thank you. Thank you so much.
يعطيك العافية عبد العزيز، بس عندي سؤال إذا ممكن.
تفضل.
طيب what residual gradient you will accept after repair؟ يعني متى you have to go back on bypass to redo the resection or when you accept the gradient? يعني what's the number?
Actually, I don't have the exact number or specific number. هذا ما هو science اللي أنا أقوله بس I think إنه less than 10. I think so. طبعا it's not science. تأليفة من عندي هذه.
طيب إذا في أحد من الشباب عنده علم بالموضوع، أنا what I know it's 15 to 20. If it is between this range or above, you have to go back. That's
I think it's for the same as Sam. For 15 or 20, you come back to bypass.
هذه نفسها للكواركتيشن right 15 to 20 الو
Yes, you are right.
أي.
And I think we have with us Dr. Shabir and we have also I think with us Dr. Farid.
دكتور عبد العزيز والله ما شاء الله تبارك الله very good lecture.
Yeah, good.
comprehensive و delivered in a simple straightforward way فيها كل ال recent guidelines برضو حليتها بشوية history. Thank you very much. I really enjoyed it. I'm sure everybody also enjoyed it as well.
Excellent presentation, Haitham. Yes, Abdullah Aziz, good presentation. Nice comprehensive lecture. Regarding this gradient, it should be less than 20. but you have to, see the rhythm and do a loading conditions. Anesthesia is a different. Sometimes it is your judgment, clinical judgment, how much you have resected. Patient may gradually drop post-operatively. Sometimes you may accept even 20, 25, but it is better to have a lower gradient. Even we operated Abdulaziz, remember one case, his gradient was just 7 or something intraoperatively. Better to have minimum gradient, and that is good, but less than 20 is acceptable. After adjusting all the, the loading conditions, everything.
Dr. Shabir, I have a technical question. Then when you resect the septum, do you have any trick to know that you are resecting only myocardium and not reaching the septal perforators? I'm asking this question because I saw when they do the ROS procedure, when they do the root, they give cardioplegia. They give the cardioplegia through the coronaries, and they look for the blood flowing through the openings. So I don't know. Do you have something like this? Any trick to do the myectomy safely without injuring the septal perforators?
No, you don't septal perforators. You don't worry about. You have to prevent only the septal VSD. VSD should not happen. You just cut the septum, but it is a clinical judgment. I don't know that there is any trick, but when you correlate the preoperative thickness in the echo, you have to keep everything in your mind. And when you cut, you know how much thickness you cut. You judge there is little bit maneuvers, as he said, put a pressure on the RB, like get the septum nicely exposed, retract the aortic valve. And when you judge the thickness, how much you have cut it. And important is not only in the thickness in the basal, in the just below the aortic valve, you should go up to the very down. And taking care of the posterior medial papillary muscle is very important here. But keep going as much down as possible, resect as much, but there is no foolproof, whether you have perforated the septum or not. To create it. This is always a fear in the surgeon. But as Aziz mentioned, it is just in the less than 1% or even less. I have done some cases, but Alhamdulillah, they did a good recovery, but we didn't have this complication. But is there specific something where you can prevent VSD? No, I don't know. And extent of resection is also important. Extent of resection, how you resect it. I think this is very important when you come to the OR, and and it is difficult to describe here. Imagination. You should always, if you get a chance, you should scrub such cases and see. And here also the papillary muscle, that are different. Sometimes the heart is rotated, as they may come from the septum. You may not be able to prevent it. You may preserve the papillary. You may have to resect, and you may have to go back to and fix the mitral valve either by the replacement, or you can relocate the papillary muscle. I have not assisted like this relocation, or it can be done, but maybe some expert hands. But for me, if you have a papillary, if you have a hukum, assess the mitral regurgitation, resect and resect as much you can. This is the visual, this one. But when you put a finger, you can also judge how much is LVT before resection. Put a finger and see. Then when you do a good resection and then you will know, you will see a fairly good amount of space you opened up.
So in general, you wouldn't.
Sorry?
So you wouldn't worry much about the coronary supply to the septum when you resect.
No. I don't know that. No, I have no idea about that. As you said, I don't know that. But you just resect it. Only thing, you should not make a VSD. That is the only thing.
Dr. Shabir, I have read one technique or trick they use for the resection of the muscle. They recommend to use number 10 blade because the depth of number 10 blade is almost 8 millimeter. So when you put the whole depth inside the myocardium, you make sure that each chunk you take, it's almost 8 millimeter. So you won't go very deep, and it's not superficial.
Yeah, yeah, yeah. You know, when you do it, it is good. And but when you go technically and do it, you know, I have seen most of the surgeons I helped or done it. You don't remove everything in a one go. You remove first one will be big chunk, then you see, then you again cut. And I have seen some surgeons even doing a scissor and cutting piecemeal. I saw one of the cases of Halis, even he was just cutting with piecemeal and removing small bits and putting the finger and assessing.
I
So
see.
yes, yeah, yeah. That is why those cases, it is good. You know, you see in a book, like, you know, take this much of blade. It is good to learn those things and keep everything. You should have a thorough knowledge. That is very important for the safety, and that is how you learn it. You cannot go without any knowledge. But you know, making those 8 millimeter, then go deep. It is not usually, but you know, practically. But then the surgeon puts their fingers and keeps on removing the small pieces as well. I'm just saying that this is a practical, you know, what I have seen.
Thank you.
But it is good idea to take a 10 blade, yeah, 10, you know, how those tricks in your mind, that might help, definitely, yes.
Yeah, as a reference point, for
Yeah,
example.
yeah. And septal perforators, I don't know why you are worried about septal perforators, because the blood supply is from the epicardium going down, right?
Yeah,
So you are cutting from the inside, not from the outside.
yeah. I
You
just had
understand
this
what I mean?
question in my mind, and I wanted to clarify. So we wouldn't worry
What I
about that.
understand by physiological point of view, it doesn't seem to be like, you know, any
Mm.
consequence, because the blood supply comes from epicardium and you are cutting from the inside. Let the perforators go, and you know, they will just go deep, and doesn't matter, you are in the cavity.
Mm. Even if you cut something, you will cut the
Yeah,
distal
yeah, yeah.
part of the vessels.
Yeah, that should be okay.
Yeah,
There's perforated, but you are cutting from the inside. You're not,
yeah, yeah.
you,
It's
yeah.
clear to me now. Yeah.
Physiologically, it should not affect what I
Yeah.
understand. Only, yeah, yeah.
Mm. Thank you
Murtada,
very much.
I
Hello,
think
Allah.
even in septal, yeah, even in alcohol septal ablation, you
Yeah.
inject the ethanol in the septal perforator to create the MI, or to create myocardial ischemia and to relieve the obstruction. So there is
Aywa.
no worry about the septal perforator.
Yeah, that explains further. It has no, yeah, that shouldn't be. But that is what
Yeah.
Aziz, you know, I'm not aware of any like any VSD post septal ablation, alcohol septal ablation. You read any literature, Aziz? Any VSD after the septal ablation?
Wallah, I didn't cross over that,
Okay.
Dr.
Okay. And second part is, you know, taking care of the mitral valve. They are actually both, you know, correlated in these diseases.
But Dr. Shabir, but in the literature, there is, يعني, the complication of VSD is higher than higher in the septal ablation than in myectomy.
The incidence of what VSD happening?
Heterogenic, yeah, VSD.
Iatrogenic VSD is higher in what?
Alcohol ablation.
In cell ablation, I think I read one article, I think, meta-analysis. I'm not sure about that, but I think
Yeah,
it
okay.
was
Could be that
a little bit
that
higher
makes
than the.
could be that makes sense, you know, because you are when you come from the top, you know, in the alcohol ablation, but in the surgery you go from the endocardium, you remove little. So, but if you
Yes.
major perforation can go everything, you know, it could be a big myocardium and can have a VSD iatrogenic. But I didn't read any literature about that, but maybe it is possible, yes.
What I know that it's not controllable procedure like surgical resection. You never
Sorry?
know how much myocardium will go.
No, I have not done that much cases, but it is difficult. But you should not fear. You know, you should go up to the base of the heart to remove as much you can. Only fear is two things you have to take care: iatrogenic VSD and the papillary muscles. These are the two things. If you have already severe MR, then go aggressive and fix your mitral valve replacement. If you see the abnormal location of the papillary muscle in the beginning, I mean, what Aziz was telling, to repair it, but the complexity, every patient is different. You have to individualize each patient and your experience also. Uh, Yeah, there are some methods of repair which we can, suppose we can do the mitral repair through the aortotomy only. One of the techniques in the hukum what we use for the mitral repair is we cut the secondary cardi. We just don't cut the primary cardi. We cut the secondary cardi, basal cardi, and it also helps us in relieving sometimes the mitral regurgitation.
You cut the secondary cord of what? Of the posterior leaflet? Dr. Shabir?
Yeah. Yes.
You cut the secondary cord of what? Which leaflet?
It will be the posterior.
Yeah. Okay. To get the cohabitation posteriorly.
Yes.
Yeah. Should have any more questions, comments?
عبد العزيز ذكرت في سلايد انه الريسك فاكتور حق الهوكم مور يعني يكون risky more in the young people او sudden cardiac death, and then in the other slide elderly people. I read it is the young people, not the elderly. I'm not sure now يعني elderly or young are more risky when they have HOCM.
Which slides?
I think the sudden cardiac death. Risky people, the people at risk.
Usually people at the risk is young people. Yeah.
في السلايدات الأخيرة في حاجة elderly people هم risky.
لا, at a premature death maybe or something. Let me check now.
Older age.
Yeah,
premature death.
Yeah.
Okay. يعطيك العافية عبد العزيز.
الله يعافيك يا هلا.
Any more questions, comments?